Well, good morning, everyone. This is the Accessibility and Disability Policy webinar series. We have with us today the Health and Human Services Commission and the Texas Education Agency to address some of the concerns and policy issues regarding COVID-19. And I'm going to turn it over to our staff, my coworker, Lindsay.
Alrighty, so thanks again to everybody for registering, and TEA and HHSC for taking the time to provide some answers. So from HHSC, we have Michelle Aletto, who's the Chief Program and Services Officer, Victoria Grady, Director of Rate Analysis, Michelle Dion Vahalik, Associate Commissioner of Long-Term Care Regulation, Joe Perez, Deputy Associate Commissioner of Rehabilitative and Independence Services, Dana Williamson, Director of Policy Development and Support for Medicaid and CHIP, Danielle Lobsinger, Government Relations, and Roxanne Medina, Disability Services Coordinator. And then for TEA, we have Justin Porter, who is the State Director of Special Education. And so with that, I think we can just, unless anybody had anything they wanted to add, we can jump right into the questions. If we can go to the next slide, Randy. All right, so we're going to start with a question that's directed to both TEA and HHSC. What is being done to ensure that policy changes consider the impact on people with disabilities and the elderly? Do these groups have a seat at the table? And if not, how can we change that? And we can maybe I'll let Justin start, since he's all by his lonesome. If he is.
Yeah, I guess I should have brought an entourage. I didn't realize that.
I know.
Good morning, everybody. So what are we doing at TEA to ensure that policy changes consider the impact on people with disabilities? And that's my whole world. So we are, beyond the work that my team is doing, all of the other teams that are working on things such as certification requirements. We had a big conversation about that yesterday. And also, if educators on the call will have seen probably instructional continuity framework that we've created. All of that work outside of special education has included folks from my team. They've been involved in all of it from the get-go to make sure that the needs of folks with disabilities, students with disabilities, served by special education and not served by special education, because it's broader than just special ed, but are considered as we go through all of that. So. We absolutely have a seat at the table, and we are voicing concerns and making changes. There was, for instance, just a good example of that has to do with teacher certification. I mentioned that earlier. We have requested a waiver from the governor for some of the testing requirements because we're not able to test folks right now, and so that has direct implication on what's going to happen next year. And so we had several conversations over the last couple of days about how that impacts teachers seeking a special education certification and what implications there are for that in the light of the federal law around the requirements for those teachers. So lots of other examples too, though. We're definitely at the table.
Thanks, Justin. And I don't know if somebody from HHSC wants to chime in, if they have any follow-up to that. If not, I'll go ahead and go to the next slide. So recent guidance, and this is for, again, both groups, recent guidance requires additional consent to provide services via telehealth prior to being able to bill. Speech and OT, so occupational therapy, had previous approval to bill, and no mention of additional consent was included. The Texas Medicaid Telecom Handbook indicates informed consent is required, but the SHARS Handbook has no such requirement. So I think we have a disconnect between whether or not consent is required. If it is, how should this consent be obtained, and is written electronic consent sufficient?
Hi, this is Dana Williamson with the Health and Human Services Commission. If a school that participates in the school and health-related services program provides instruction to a Medicaid eligible student during this time, the school may seek Medicaid reimbursement for SHARS services delivered through telemedicine or telehealth, assuming all other SHARS program requirements are met. Distance site telemedicine and telehealth providers must obtain informed consent to treatment from the patient, patient's parent, or the patient's legal guardian prior to rendering a telemedicine or telehealth service. Consent may be written or verbal and must be documented in the student's medical records.
Perfect. So next slide, if we can. Who can districts contact if they have SHARS-specific billing questions? Because I think we got quite a few of those.
This is Dana Williamson again. We'd be happy to provide that information, and we can I don't have it with me at this moment, but we can certainly provide the information as a follow-up to this webinar.
Thank you, Dana. Next slide, we'll go to our TEA specific questions. How can special education students continue to best receive services and have their ARD requirements met?
That is the million-dollar question. And there's in an unprecedented event like this, there's not an answer to that question. LEAs need to look at the specific situation, the specific needs of the students, and make all reasonable efforts that they can to implement the IEP as it was written by the ARD committee. There really just is not a silver bullet answer to this, and the reality is kids are not going to get everything that they should be getting. It's just not possible. And so we've been tried to be really transparent about that with families, emphasize the importance of, on the part of LEAs, to be communicating with families and include them in the planning process for how we are going to meet whatever needs we can meet during this time, and what those reasonable efforts are going to look like from the LEA standpoint and from the parent standpoint, because so much of what's going to happen is, or what is happening right now, is reliant upon parent involvement. The parents are in many cases the teacher, and so there's limitations there with regard to how much time does the parent actually have, and when I say parent, I should be saying parents and families, how much time do they actually have to devote in their day to meeting the needs of that one student, and how are we going to document what's happening and what's going forward there. So really that's been our guidance over and over again, is first and foremost communicate with families about what can and cannot be done in the current situation, and then make sure that we're doing everything we can to document kind of the delta between what should be what the student would be getting in a brick and mortar setting and what they're able to get now, because all of that is going to have to be considered when we do get back to school and look at how we're going to try to make up for these services.
All right, next question. What are TEA's expectations for the 2020-2021 school year? Are there plans in place to address the mental health needs of all students, including special education students, following what's been a fairly traumatic event?
So just to be clear, mental health isn't necessarily a special education issue. So I'm gonna answer this from a special ed standpoint, but also like direct to other folks within TEA that support mental health needs of kids and families. And then also, obviously, HHSC might have something they want to weigh in on here. But so our expectations for the 2021 school year, that is a little nebulous. So we're talking just specifically about what folks do with regard to mental health. We are providing in the next TEA, not special education, but TEA is providing in the next probably 2 to 7 days, quite a bit of resources around mental health and some guiding questions and some things that LEA should be considering when they're trying to meet the needs of students who may be, like you said, experiencing trauma based on this. And that just speaks also very broadly to an emphasis that we have in Texas now as being part of Project Aware and a couple other things, a grant that we've received from the federal government, the Royal We TEA, not special ed, to assist LEAs in meeting the needs of students with mental health concerns. So yeah, again, there's not a silver bullet answer to that, but we are working on resources and providing them as quickly as they can be put out. Those are more geared towards the current state of events, what we're doing right now, because whenever you add a level of stress to a scenario like we're doing right now, that's certainly going to cause some mental health issues that may have been underlying to bubble up. And so that's kind of the way the guidance right now is working. But we also understand that there's going to be, that the landscape has changed dramatically, and there's going to be a need for continued support and resources once we get back to school.
Absolutely. Okay, next question. Can districts elect not to meet federal special education evaluation timelines because of limited resources?
So the answer to that question is no. They can't elect to not meet the timelines. There's no flexibility given there's no flexibility available in IDEA for either the state or the federal government to give any flexibility in those timelines. So the answer is no, they cannot elect to miss the timeline. There is acknowledgement on the part of the Department of Education, Office for Special Education Programs, and TEA that we know timelines are going to be missed. There's no way around it. There are some pieces of, not every timeline is going to be missed, but there are some pieces of an evaluation that cannot be done either effectively or ethically in a virtual environment. And so we've guided districts to prioritize the health and safety of students, staff, and communities above all else. And that means that in some cases, they're not going to be able to complete those evaluations on time. And so the guidance has also been that they should then, going forward, document all reasonable efforts. You're going to hear me say reasonable efforts over and over again. They need to document their reasonable efforts to complete those evaluations within timelines, and also document all the communications they've had with families about it. We cannot emphasize enough the importance of LEAs communicating with families about timelines, about services, about all of that. So.
Okay, next question. For those 3-year-old children with disabilities whose initial evaluation by ECI was not completed before aging out of Part C of IDEA, will the school districts that found them eligible through ECI provide them with compensatory services, or will local ECI providers be responsible? And I can read that again if need be.
So I think I think that HHSC is probably going to want to weigh in on this question as well. From the evaluation standpoint, and again, ECI is not under our purview, but the transition from ECI to something that we're heavily involved in, obviously, at TEA. So if eligibility was not determined for Part C, then the child would be considered an initial evaluation for Part B, and timelines around that would apply for that child. But again, it goes back to the last question of we know that a lot of those pieces of evaluation are not going to be able to be met in this virtual environment that we find ourselves in. And so those timelines, are likely to not necessarily be met, but they should therefore document everything they did to make that happen. And so compensatory services is a big question of across the board. And you can look at it a couple of different ways. We definitely want, the guidance from TEA is definitely that LEAs should be keeping track of everything that a student would have been availed as part of FAPE had none of this been happening, and then use that information and any other, and we'll talk about it later, there's a later question about regression, and talk about how that impacts services going forward. In a lot of cases, just to set expectations for people, their compensatory services or additional services to address regression, it's not necessarily in the student's best interest to look at that in a minute-to-minute, one-to-one sort of thing, because there's only so much that those little sponges can absorb at one time in some cases, and so those need to be made very much on an individual basis for with considering the needs of the student first and foremost, and their ability to cope and to overcome any regression that's happened. So, and you're going to hear me say that again next time compensatory services come up, because we're trying to be really clear in that guidance that it's not, there's nothing in that where X equals Y in special education. You are always looking at the individual situation, the individual needs of the student, and trying to make decisions as a group with consensus in the ARD meeting about what is the best decision for that child. So, and HHSC might want to weigh in on this as well.
I'll give him a second if anybody has anything to add to that.
This is Roxanne Medina. We will be sharing an answer with that later in a written response.
All right, next slide. This is essentially the same question, I think, if we want to go to the next slide. So similarly, for children who did not receive ECI services per their IEP before transitioning to Part B, will school districts provide compensatory services, or will local providers be responsible?
So I think that question again is decisions will have to be made on an individual basis. If this is who's responsible for those compensatory services, I think that's a much bigger question. It depends. It also is going to depend on what's appropriate at that time for that individual kiddo. There's not a blanket answer for that. I get asked questions about who's responsible for compensatory services all the time, and the answer always is you have to make those decisions on a case-by-case basis.
Absolutely. Okay, next question. Does a district need to document what can and can't be provided right now for students on both IEPs and 504 plans? Is it necessary to communicate these changes with parents and/or obtain their approval? This is a three-parter here. What liability does a district create if they don't document the change of placement? And what is a reasonable time frame for a district to accomplish this in terms of instructional days under their COVID-19 model? That's really 4 questions for you in one.
So yes, a district needs to document what they're able to provide and what they're not able to provide, and first and foremost, all of the communication that happened around that with the family, in the planning, how the family was involved in planning for meeting those needs, for what services were able to be provided and what were not. That they need to document that extremely carefully. So this other question here: what liability does a district? I'm sorry, I'm going to jump back up. Is it necessary to communicate these changes with families? Absolutely. In the guidance that we've given around, we have something posted on our website that is an emergency change of services documentation form. It's totally optional. LEAs don't have to use it, but it really walks them through sort of what's the plan for this student in this interim. And the thing that is probably the most positive about that form is that it's time delineated, because what we're trying to avoid is our committees convening, creating entirely new IEPs that are designed for this anomalous situation, and then that kiddo has that IEP. When we come back to brick and mortar school, you have to go back and undo all of that, and there's a lag. There's going to be time when this kid's going to be living with this IEP that really isn't what should be in place for him when we're able to, in a brick and mortar setting, when we're able to avail them of a whole lot more services. This temporary plan could serve as an amendment to the ARD, amendment by consent. If they go through the process and then the parent agrees to it and they can document that agreement, this is now considered to be an ARD amendment or an amendment to an IEP by agreement. And so that sort of covers them for consent and for planning. They don't have, we're not telling them they have to use this form, but we are saying it's useful for that documentation, and if they can document agreement from the parent, which the very first thing they should be doing is consulting with the family and bringing them in and talking them through all of this. If you do that and they're part of the whole process, the likelihood that you're going to have agreement is pretty high. Document that agreement, and now when we get back to brick and mortar, this plan, it's already part of the plan that it ends. As soon as we get back to brick and mortar school face-to-face, this plan ends and the original IEP goes back into effect. So there's not a need to go back to ARD, there's not a need to redo paperwork, there's not a lag between when we can actually get all this paperwork done for all of the thousands of kids that we have in the state of Texas who would need that. It just automatically goes back to the original IEP. That's kind of why that's been our guidance and why we've pushed LEAs to use that. It is optional. We don't have the authority to force them to. And we wouldn't. We have no local control in Texas, and so it's their decision. The other question here about change of placement. So there's a lot of confusion right now about this, and I think there are some attorneys groups who are adding to that confusion. Just taking services and moving them from brick and mortar setting to a virtual environment in and of itself is not a change of placement. It's a change in location, which should be documented through an amendment by agreement or whatever process you have locally for documenting change in location. It doesn't necessarily mean the entire ARD committee has to convene and go through that whole process, because it's a change in location, not a change in placement. So now, that's just if the same services are being afforded here that we're now doing here, that's the change in location. If we're changing placement, that's a much more significant change to what's being provided to a student. And that is required to be documented by our committee. The liability, obviously, I've said this over and over again, the risk of liability increases exponentially with limited communication. So if you're not communicating with families, you're creating much more liability for yourself than if you are communicating with families and bringing them in through the whole process and making them part of the planning and documenting all of that. Obviously, if folks feel that things are being done to them, you are creating liability for yourself, and that's just the way that is. I have said that over and over again to LEAs, just encouraging them to over communicate with families and make sure that they are part of the process, the planning process, not just being told how things are going to happen or what their limited options are, but bringing them in and working with them. Reasonable time frame. So, I mean, it goes back to the legal test of reasonable and whether or not they were doing everything that they could reasonably do in that time frame to document that. I think again, it goes back to the best way for districts to reduce liability for themselves is to over communicate with families and make sure that families are brought in and part of that decision-making process. I'm not talking about blanket one-size-fits-all newsletters. I'm talking about calls to parents that are documented. I'm talking about virtual conversations, whatever it has to be, so that we can actually bring them in and have them part of the decision-making process.
All right, next question, and I'll try to keep us going a little bit. I'm cognizant of the time. I want to make sure we get to as much.
Cut me off if you need to. I talk too much.
No. I think everybody really appreciates your answers. These are all really excellent questions. What kind of flexibility do districts have in terms of electing which ARD and 504 meetings to have? And we'll just answer that part of the question.
They don't have any flexibility. That's the thing. There is no flexibility built into IDEA around this. Section 504 is a little bit more. It's not a little bit. It's quite a bit more nebulous, and so that's a different story. Our guidance is always in your 504 meetings and documentation. If you follow special education timelines and procedures, you're going to be good with federal law because there's nothing laid out in 504 that tells folks how to do that. It's much more open and sort of leaves them open to sort of interpretation. So our guidance is always that in section 504, you should follow similar processes and timelines to what you do with special education. But there isn't any flexibility. And again, they need to just be documenting all their reasonable efforts to comply with required timelines and again, document that communication with families.
All right, next question. Many school districts are providing reduced instructional hours with fewer auxiliary services or related services support. How are deaf and hard of hearing students doing without interpreters?
So this is a really specific question that I'm not going to have a really specific answer for. What I can say is that we work with our partners at TSBVI and TSD and the regional day schools for the deaf, and also our partners at Region 11, who hold our sensory supports network to be sure that we're providing all of the guidance and supports that they need. So they're constantly reaching out to their teachers. They have a very close relationship. All of those entities have a close relationship with the teachers in the state who work with our deaf and hard of hearing students. We are providing them with resources and guidance as they need it, but I can't really answer how those kiddos are doing right now. We just don't have that information.
Okay, next question, and I think you kind of answered this one already. It's another question about is there a plan in place for compensatory services? And I think I heard it's really going to be a kid by kid basis. So we can go to the next question. How can schools effectively measure regression and loss of skill for students who aren't receiving the minutes of intervention in their plan? How should schools think about this for dyslexic students? And what is the minimum amount of data that should be gathered?
So we can't tell you what the minimum amount of data is because again, it's the individual in IDEA. It's on a case-by-case basis, but they should be documenting again as they go through the process, not only what services are being provided, but all that progress monitoring that they're doing. We have a couple of resources around progress monitoring during this time that are really more around guiding questions and considerations for what you're going to do for progress monitoring. But all of that data is going to be very, very helpful when we come back. The idea around regression isn't unique to this situation. There's lots of other times. So this is something that evaluation staff should understand how to do, and this is something that LEAs already kind of know how to do when they look at extended breaks, anything else. When we have a regression, there's lots of different data points that it could require them to do some additional assessment. It could require them just to look at the existing data around present levels of performance and that progress monitoring as we go through that. But again, it's going to be an individual basis. There's not anything different for that for students with dyslexia. That would be any different than we would look at for anybody else. The same types of data, what we should be collecting, progress monitoring, present levels of performance before and after, and what needs to happen to affect that delta.
And I think that leads nicely into our next question, which is, are schools required to share progress monitoring data with parents?
So that's made on an individual basis. Some IEPs don't have a requirement for progress monitoring. I think by and large, most of them do. And so it's the same, it's not any different than any other requirement in the IEP. Districts have an obligation to fulfill the requirements of the IEP. And if one of those is progress monitoring, they have a duty to do that. And so, but what I will say is that it's likely to look different based on the current scenario than it would obviously in a brick and mortar setting. We have a question about this in our Q&A posted to the TEA COVID resources page. And it's specifically about progress monitoring. We also have a document, I'm not sure, yes, it has been posted, sorry. It's hard to remember what's been posted and what's in the pike. But we have that is some guiding questions about progress monitoring, how you should be thinking about it and how you could be communicating that with families. But again, yeah, if it's in the IEP, they do have an obligation to do it. It's gonna look different right now because of the situation though.
Gotcha. And we just have 4 more TEA questions. So we can go to the next slide. Yeah, here we go. State schools such as the Texas School for the Deaf and the Texas School for the Blind and Visually Impaired have compensatory services year-round. Do we know how COVID-19 will impact those programs?
So I don't really think we're talking about, I don't really think this question, and someone correct me if I'm wrong, I don't really think they're talking about compensatory services year-round, because again, compensatory is on a student-by-student basis based on their scenario. All LEAs have the opportunity to provide compensatory services whenever they need to. For instance, I think what this is really getting at is around extended school year and what's happening during the summer. Extended school year is a very specific program for for a group of students who experience regression if they're out of school for very long, so we do ESY. As you're doing ESY, you have a principal on hand, you have cafeteria staff, you have other people on hand. And so what a lot of LEAs do is they leverage the fact that they have all that infrastructure in place, and students who need compensatory services go to the same campus or in the same scenario as those kiddos who are getting ESY, and then the expense is sort of diffused a little bit because you have that infrastructure in place. And so this isn't any different for TSD or TSBBI. Those schools are going to do the same thing. They're going to make student by student decisions based on what compensatory services are necessary. And if that means that they're going to make things available for students during the summer at the same time that they're doing ESY, they might do it in a different way. But they have long-standing processes in place for how they determine whether or not students are going to need compensatory or additional. Like, some LEAs are getting very hung up on the fact that we're using this term compensatory services in a much broader way than it's defined in law. And so just sort of understand that that's an ether too, that compensatory services, an LEA may be calling them additional services, they may be calling them additional supports and not calling them compensatory services for some legal reasons, but know that we're talking about the same thing. This question is not any different for any other LEA than it is for TSD or TSB.
Gotcha. Okay, next question. It's long, but it's simple. The Texas Department of Agriculture guidance states students enrolled in programs for people aged 18 and older, as well as students older than 18 who have re-enrolled, are eligible for access to meals at distribution sites. However, districts are using language that states meals are only available for students 18 years of age or younger. Will TDA or TEA, and I realize this may be out of your purview, Justin, will they direct districts to update their messaging to parents via email, text, etc., to clarify that these students are eligible for meals?
Yeah, this has been bubbling up for a couple of weeks as soon as this has all started, and so it is a TDA question. It's not a TEA question, but they're my kids, and so I have jumped in and pushed pretty hard. And TDA has never been. This has not been a problem for them. They've not denied this, but there has been some lack of clarity about what information has been available to LEAs as they're determining all of this. And so we worked with TDA to create a question in their Q&A about this specifically, and it's posted to their website now. So I will send the link to that Q&A to Ron or this group, and y'all can help get it out to participants so they have a place to point folks when they are having this question in an LEA.
Yeah, that's wonderful. Okay, next question. IDEA Part C requires written consent from parents for children to receive services virtually. However, many of our families don't have access to the technology necessary to provide signatures electronically, and many of these families are in great need of access to these services. Since this is a federal regulation, is the state in touch with OSEP to try and get guidance on alternative methods of parental consent?
So this is an HHSC question. Danielle and I kind of circled up on this late yesterday about it, but someone from HHSC will have to address that because it's ECI.
I don't know if there's somebody who wants to hop in and answer that now.
This is Roxanne Medina. We'll be providing a written answer at a later date.
Alrighty, and then this is our last TEA question. Who can people contact if schools are not fulfilling their duties during COVID-19? Who should they contact if district administrators and personnel are not responding to communication?
So that's sort of two parts. So if the best place, I'm going to answer the second part first. Who should they contact if district administrators and personnel are not responding to communication? That needs to be handled. I mean, that needs to be handled at the local level to the degree possible. That's what their superintendents are for. That's what their school boards are for. That's who they should. If they're not getting answers from their folks, that's who they should be contacting. School board members, superintendent's office, executive members of staff there. They should be going up the chain. And then if districts aren't doing what they need to do, if there's a compliance issue here, they really should be referred to the special education complaints process. And that is the venue for if an LEA is failing to make that reasonable effort, or as we do this, as we go through this process together, that's what the special education complaints process is for. And folks can find information about that on the special education section of the TA website.
Alrighty, thank you, Justin, for all of your answers. I know everybody really appreciates it. And so now we'll switch gears and go over to HHSC. If we can go.
Real quick, Lindsay, can we let HHSC introduce themselves? I think we kind of skipped that by accident.
I introduced them at the beginning, but if they want to really quickly.
They wanted to, I think, share a little bit about their agency.
Yeah, just super quickly.
Hi everyone. This is Michelle Leto, Chief Program and Services Officer with HHSC. Just wanted to make a note on behalf of our team that we appreciate the conversation today and plan to follow up expeditiously on the questions that we're not able to answer today, as Roxanne has indicated. And forums like this are important to us. To speak to an earlier question that we didn't jump in on, although some of our regular committees have had to be canceled or postponed due to social distancing requirements to keep everyone safe and healthy, we've really ramped up opportunities like today, weekly stakeholder calls, as well as scanning our program email boxes to make sure that your concerns, questions, and ideas are incorporated into some of the policy changes we're talking about today. So I appreciate the opportunity for me and the team to be with you, and we can get back to the questions. I know we're pressed for time.
Alrighty, so first question, and I think we have Joe here, I didn't check. What is the Office for Deaf and Hard of Hearing, or ODHHS, doing to mediate between the deaf community and HHSC during the pandemic?
Yeah, hi, this is Joe Perez. I am here. So the Office of Deaf and Hard of Hearing Services continues to work with the community to address concerns, and the program continues to partner with other divisions in the agency to make sure information is accessible. And additionally, the program is the central point of contact for coordinating interpreting services and CART, communication access real-time translation services for external communications.
Yeah, next slide. What is the plan for people who are hospitalized and need assistance in order to receive effective communication? So I think we had a lot of questions about what if somebody needs a sign language interpreter? What if somebody has a profound intellectual disability and they need a personal care attendant to help them understand what is going on? What is the plan for that? Or is there a plan? Or is there somebody that people can contact if they have questions?
Michelle Dion-Vahalik, are you on the line?
I am. Sorry, I was unmuting myself. Good morning. HHSC issued an April 6 emergency rule, GO 20-2015, that prohibits all visitors except persons providing critical assistance from entering a hospital and provides criteria for hospitals must follow prior to allowing entry. The emergency rule also defines providers of essential services, persons with legal authority to enter, and persons providing critical assistance.
All righty, I suppose we can go to the next slide. How is HHSC ensuring community, let me make sure we have the correct questions here. Yes. How is HHSC ensuring community attendants, group home staff, and other frontline workers are getting masks, gloves, and gowns when they're providing in-home services?
This is Michelle Dion-Vahalik again, and HHSC, we understand there is a lack of PPE, and the lack of PPE has impacted all healthcare providers, including providers in the community. Unfortunately, there's a nationwide shortage of PPE. Following the guidance from the Centers for Disease Control and Texas Department of State Health Services, HHSC has released information in a frequently asked questions document about the differences between a face mask and an N95 respirator. What you can do to optimize the use of masks and N95 respirators, and how to request PPE through your local emergency management to your regional advisory council in Texas. If you're not familiar with the HHSC COVID-19 page, you can Google it and it will immediately populate for you. And as you navigate through that COVID-19 page, you can click on the button to the right that has providers, and you'll find the PPE guidance that I am referring to. The use of PPE for any direct care staff is important. If an individual in the home has an active case of COVID-19, as it will reduce the risk to staff members and other individuals in the residence. If there is not an active case in a resident, staff members should be taking all infection control measures such as distancing, frequent disinfecting, increased hand hygiene, use of cloth or surgical masks, use of gloves for hands when providing hands-on care with individuals, and then declining non-essential visitors to reduce the risk to individuals and staff in the home. Home masks can be used and have been encouraged by the Centers for Disease Control to reduce the risk of spread of COVID-19 during day-to-day activities. If there are no active cases of COVID-19, these types of masks can be used. If there is an active case of COVID-19, PPE then needs to be used in an appropriate mask as well, be it a surgical mask or a droplet precaution mask. You can find more information about PPE and ways to optimize its use by visiting the CDC and Texas Department of State Health Services.
Thank you. Next slide. What is the plan for group homes where staff or residents have tested positive? Staff are often pulled into coverage on other homes, which creates a serious contamination issue.
This is Michelle Dion-Vahalik again. If an individual at a group home or an ICF has tested positive for COVID-19, the provider should isolate that individual and continue to provide care using personal protective equipment. All appropriate notifications to the provider's nurse, individual's physician, local health department, or Department of State Health Services and Health and Human Services should be made. Other individuals in the residence should be kept away from that individual who has been diagnosed, as well as actively screening that individual for fever or respiratory signs and symptoms or other symptoms that the individual may be reporting. Before entering the room of the individual who has an active case, staff should put on PPE. Cleaning should occur regularly to disinfect commonly touched surfaces such as doorknobs, countertops, light switches. Staff should also practice appropriate hand hygiene. If staff have been exposed without the use of PPE, they should notify the program provider, self-quarantine in their homes, and monitor themselves for symptoms. If staff have been tested positive or are exhibiting symptoms of a respiratory infection, they should not report to work. Program providers should track what residences the staff members were working in and increase screening and monitoring of those individuals living in the households. As part of their infection control program, an ICF should look at their staffing policies to determine if they can keep from sharing staff across multiple homes. If possible, we encourage them to limit staff to providing care at one home instead of sharing staff across 2 or more homes. Also, if possible, within each home, they should have dedicated staff to care for those individuals who are ill and for those who are not ill.
Okie doke. Next slide. What is being done for staff who work on homes, both in the community and in ICFs with COVID positive residents? I think this is direct, I'll finish the question. They may be going home to high-risk family members and spreading the disease. Is there a plan to provide them housing in hotels similar to what is being done for other healthcare providers?
So for community-based and ICF providers, there's not a plan to provide housing in hotels from Health and Human Services. It's very similar to the guidance I just gave before. If an individual at a group home or an ICF has tested positive, the provider should isolate that individual but continue to provide care and services. The care and services being provided to the individual who is positive should include, that healthcare worker using PPE and then the appropriate disinfectants to ensure that the environment is kept as clean as possible. And again, just a reminder that the provider should notify the provider's nurse, individual's physician, local health department, or Department of State Health Services, and Health and Human Services. Other individuals, should be kept away from that individual to the best of everyone's ability so that there isn't any cross-contamination. And then again, ICS should look at their staffing policies to determine if they can keep from sharing staff across multiple homes, as well as trying to keep staff in the home if there is more than one caregiver, one staff working with someone who's in isolation and the other staff member working with those who may not be in isolation. It's almost very similar, identical to the guidance that I gave in the question before.
Okay, next slide. Many people with disabilities use personal care attendants who in turn are having to work overtime. What are the plans to make sure that these essential workers get paid?
This is Victoria Grady. I'm the Director of Rate Analysis for the Health and Human Services Commission. Texas HHSC is committed to ensuring access to home community-based services and serving people in the most appropriate setting. HHSC has fully implemented the reimbursement rates to increase the minimum wage for community attendants and to award all funding for the attendant compensation rate enhancement program with the funding that was appropriated in House Bill 1. With the support of a variety of stakeholders, we are developing a strategic plan for recruitment and retention of community attendants and the promoting independence policies and plan. We're also working to improve self-directed services and person-centered practices. HHSC is also seeking ways to increase flexibility for community programs during the COVID-19 pandemic.
Thank you. Next slide. Will HHSC coordinate with the managed care, home care, disability, and aging communities to develop regional plans to increase the pool of community attendants?
HHSC works with our managed care organizations and our fee-for-service providers on a daily basis and are working actively to ensure that clients are receiving all medically necessary services. To the extent that you are experiencing any challenges with receiving services, that are required for care of you or your loved one, please contact HHSC, and we can provide the contact information in writing, so that way we can make sure you get outreach from either your fee-for-service provider or your managed care organization.
Okay, next slide. If there is an initiative to hire more community attendants, does this initiative include plans for hazard pay and provision of PPE?
HHSC has received a lot of information about increased costs that providers may be experiencing to continue providing services, including increases in wages or the provision of PPE. We're currently evaluating all of those requests and anticipate that we will be looking for opportunities to provide financial resources in the coming weeks.
Next question. Personal care attendants, these are all sort of in this similar vein. Personal care attendants provide life-saving essential care, but currently make only $8 to $9 an hour. Is the state considering raising the wage to be more in line with other essential employers, like at the HEB grocery store? Considering that their work may help keep people out of the hospital, this seems like a practical and moral issue. And I think I just heard you say y'all are constantly looking at ways to address that in the last question.
Yes.
Okay, next slide then. How can HHSC work to get community attendants health insurance and sick leave?
So HHSC, as I mentioned before, is working on a strategic plan for the recruitment and retention of community attendant services. And that work was actually ongoing prior to the COVID-19 pandemic. And so it is through that plan that we're looking at options, which would include health insurance or sick leave. We're also working with our federal partners to ensure that we're able to provide state level solutions that complement the federal relief options that our federal partners are working on.
Great. The specialized, and I think this is for Joe, the Specialized Telecommunications Assistance Program, or STAP, through DHHS is at a standstill. Contracted staff are not allowed to bill the state for not meeting program goals. No applications, no fee. Are there plans for alternatives to continue the waiver, or will the program and its contracted staff be furloughed altogether?
Yeah, hi, this is Joe. Yeah, flexibilities for staff, such as allowing and bypassing the need for the need to meet the applicant in person, that has already been implemented and shared with the staff coordinators, and we continue to seek options, additional options for flexibilities.
Okay, next slide. What are the plans to, and you may have just answered this, what are the plans to provide flexibility to the Deaf and Hard of Hearing Access and Technology Specialist Program?
Yeah, it is a similar answer. We continue to seek options that would allow us to implement additional flexibilities for the program.
Okay, next, can HHSC suspend and or delay the implementation of the electronic visit verification, EVV, requirements?
This is Dana Williamson with Medicaid CHIP with HHSC. And the electronic visit verification January 1st, 2021 deadline for implementation is actually in federal statute. So the state does not have the authority to extend this deadline. It would really require action at a congressional level, United States congressional level, to change that deadline.
Gotcha.
So
okay.
we're certainly looking at what we can do to, be as prepared as possible given the challenges with COVID.
Right, yes. Okay, next question. COVID-19 has significantly impacted programs and service providers going into skilled nursing facilities. While the timeline for the pandemic is unknown, what discussions, if any, has the state had regarding how to better protect our vulnerable populations in skilled nursing facilities moving forward once the facilities are no longer on lockdown? So I think the question is just what is the plan for when we can go back into those nursing facilities to keep people safe?
So this is Michelle Deonzaholic in long-term care regulatory. HHSC is continuing to monitor guidance from the Centers for Medicare and Medicaid Services, along with the Department of State Health Services and the Centers for Disease Control, and will follow all recommendations from those entities in consideration of any executive direction. We have issued guidance and are issuing guidance on a continuous basis for nursing facilities. The most recent revision released for nursing facilities, which is a response plan, meaning current action, just went out yesterday. We are also continuing currently today to conduct some survey-related activities, and we are monitoring facilities throughout the COVID-19 outbreak.
Okay, next question. Will the recently approved 1135 Medicaid waiver affect in-home supports? How should we communicate with consumers and families about the changes that waiver will bring?
This is Dana Williamson again. March 30th, HHSC received a partial approval for the items that were submitted under the 1135 authority. A list of the approved flexibilities that became effective March 1st to assist providers and benefit individuals receiving services is the following. We extended pre-existing authorizations for which a beneficiary has previously received prior authorization through the end of the public health emergency. We have suspended pre-admission screening and annual resident review level 1 and level 2 assessments for 30 days. The state fair hearing requests and appeal timelines have been extended to request a fair hearing from 90 days to 120. For provider enrollment, we've allowed greater flexibility to pay claims from out-of-state providers and enroll out-of-state providers. Providers who are not already enrolled as Medicare providers or Medicaid providers in another state can be enrolled through a more flexible process. We have also temporarily discontinued revalidation efforts of currently enrolled providers. We have also been able to waive public notice requirements so that we can more expeditiously submit state plan amendments that are related to disaster waivers. We continue to look at the different federal authorities that we need to request additional waivers under. This is an ongoing process that we are working towards in terms of the requests that we're receiving from our external stakeholders, our providers, individuals receiving services. So this is an ongoing effort by HHSC to continue to evaluate the need to request more waivers.
Okay, next question. What is being done to prevent the spread of infection in state hospitals and state-supported living centers? What about nursing homes? So I think just institutional settings in general.
Sure, this is Michelle Leto. I'm happy to take that one and then see if Michelle, the other Michelle, has anything to add on the nursing home side. For SSLCs, we very early on started limiting visitors and unnecessary workers to our campuses. Of course, we've tried as hard as we can to make sure that our folks at SSLCs are able to communicate with their families through FaceTime and other outlets, and have made exceptions where it's really fundamental to patient care to have some in-person visits with family, but from a healthy, socially distant location. We also have early on started screening staff, taking their temperatures, questioning them about symptoms to make sure that they're not coming onto campus if they are symptomatic. Of course, what we know now about contagion prior to symptoms has created a unique challenge for us. But these, of course, are essential staff, and we do our very best to make sure that they have the personal protective equipment, masks, when we know that infection spread indicates that they do so. We also, on our campuses, are fortunate for most of them to have space, even separate buildings, to isolate when residents become positive. So we've been able to do that to also try to suppress any spread of infection on campus. And so I'll stop there and see if Michelle has anything to add on the nursing facility side.
Thank you, Michelle. This is Michelle Dion-Vahalik in Long-Term Care Regulatory. So Long-Term Care Regulatory has asked providers to limit access to facilities to only essential visitors providing critical assistance, while at the same time increasing their infection prevention and control efforts, which includes proper screening of anyone entering the facility. These actions will reduce the risk to these vulnerable populations and the people caring for them. We are working with our providers daily to help ensure that they know what to do for an infection prevention and control steps to limit the spread of COVID-19, to help get the supplies and support they need to continue their vital work. I did mention that we did release a plan specific for nursing facilities that actually provides guidance in relation to setting up isolation wings, dedicating certain halls, buildings for those needing to be cared for because they do have COVID-19. We've provided tools to help providers with staff utilization, the use of PPE, hand hygiene, and social distancing. We waived certain requirements so that it is easier to hire certified nurse aides, medication aides, to allow more flexibility for extended leave for residents and other administrative requirements so that providers can focus on caring for the individuals living within their facilities. We've also adopted emergency rules about actions providers need to take because of COVID-19 and the vulnerable individuals that they are serving. All of this can be found on the HHSC COVID-19 webpage.
Wonderful, thank you. Next slide. Do you know where we can find guidance regarding people being discharged from nursing homes or rehab facilities into HCS Group homes?
This is Dana Williamson. I wanted to just real briefly on the prior question about the 1135, I just wanted to add briefly to that in terms of how we're communicating that information out to individuals and providers, Medicaid CHIP is holding weekly webinars that is open to anyone that wants to participate. And we also have specific, as I think has been previously mentioned on this webinar, we have specific COVID pages on our HHSC website where we are posting, continuously posting guidance and information for providers and for the general public. So I just wanted to add that. And in relationship to the question about discharge from nursing homes, at this time, we have provided guidance in an information letter. It's 2020-15. HHSC is postponing the release of home and community-based interest list reduction slots through the end of April 2020. And this was done because of concerns about the required face-to-face interactions that would be necessary to help individuals enroll into the waiver programs. So HHSC is really reevaluating the release of HCS interest list reduction slots, and we will certainly be issuing further guidance about whether we will continue to postpone this in the month of May, or if there will be different guidance. There are individuals that at the time shelter-in-place orders were given out that were in the process of enrolling in the HCS waiver. And so HHSC has been working very closely with the local intellectual and developmental disability authorities to complete those enrollments using telephonic, telehealth, or telemedicine if it is possible. We are working with our local authorities to continue, if there are crisis situations, there is the availability to enroll in the HCS waiver via a crisis diversion slot or a nursing facility diversion slot. There's also the ability for individuals that are aging out of the foster care system that are in a more urgent need of waiver supports to be able to enroll. So we're continuing to enroll individuals who really are experiencing a crisis or have no other options for continued care and supervision and safety.
Okay, next question. Agencies with multiple group homes are struggling with buying limits in stores when they shop for groceries and supplies. Can you provide them some sort of special allowance to buy multiples based on the number of group homes or residents and staff? Simple things like bread are very difficult to get in sufficient quantities.
This is Dana Williamson. We have received this feedback as well through our communication channels with providers and our weekly webinars. And we were able to develop a letter that has been distributed to HCS 3 and 4 bed group home providers, and also to our smaller community-based intermediate care facility providers. It basically explains to the stores that these providers are Medicaid providers and that they have a responsibility to ensure the health and safety, the need for food and personal care items for these residential settings, and it requests that the store allow these providers to purchase above the minimums that are, or the quantities that stores are allowing. We, of course, can't force the store to change its policies, but we certainly are issuing the information in the hopes that providers will be able to obtain more supplies.
Okay, next question. Is it possible for the state to increase funding for lifespan respite care to the Aging and Disability Resource Centers? We had some additional funding we're not using, but were advised by HHS we could not use it for respite care for parents of children with special needs or caregivers for older adults whose day centers were closed because the legislature only voted a certain amount of funding for the lifespan respite care program.
Sure, this is Michelle Leto, and I'll take that one. ADRCs can use their general fund to increase their lifespan respite care program budgets if they decide to do so. But there are funding streams, of course, that require that are mandated for other purposes in law that would require approval outside of HHSC, either from the Office of the Governor or from the legislature. So, but the general fund that they have in their budgets, if they choose to do so, can be used to fund lifespan respite care.
Okay, next question. It's a long one. What guidance is HHSC providing to hospitals pertaining to individuals with disabilities needing their state-funded personal support workers to assist them with communication, specific ADLs that take extensive time, and other disability in a hospital setting? Right now, many people with disabilities are terrified of going into the hospital setting, knowing that hospital staff will be taxed. Can people with disabilities bring their personal support workers with them to the hospital? Where can people find hospital policies on visitation or personal support at this time? Is there a centralized place people can go to find these policies on personal care attendants? Is HHSC or DSHS considering working with the Joint Commission or someone similar to deliver overarching guidance?
Hi, this is Michelle Dion-Vahalik again, and I'm going to go ahead and answer this one for the hospital or the healthcare quality side of regulatory. I mentioned earlier that HHSC had issued guidance on April the 6th and an emergency rule, GL 20-2015, that prohibits all visitors except persons providing critical assistance from entering a hospital and provides criteria for hospitals that they must follow prior to allowing entry. A state-funded personal support worker can be considered a designated caregiver under Texas Administrative Code 133.51 small d 1, or an essential visitor performing official duties under Texas Administrative Code 133.51 small d 2. Hospital policies on this issue are specific to each facility. However, the Texas Department of State Health Services has resources and guidance for hospitals and healthcare professionals as well. And I'm going to guide folks back to the HHSC COVID-19 webpage for this specific information. Again, you'll click on the right-hand side provider, and you'll navigate to the hospital requirements underneath the Regulatory Services Division tab. And you'll be able to find these emergency rules as well as any provider guidance around this.
Okay, next question. What is ODHHS doing to ensure public and state sites, and I think they mean websites, are accessible to deaf and hard of hearing? What information are they disseminating?
Yeah, hi, this is Joe. The CDC has released a number of videos in American Sign Language pertaining to COVID-19, and the Office of Deaf Hard of Hearing Service, along with many of its partners, to include Texas Department of State Health Services, National Association of the Deaf, Texas Association of the Deaf, and all of our contractors. We've all shared the videos with our stakeholders. Also, Governor Abbott's press conferences have been supported by certified interpreters, and our contractors have also been monitoring local press conferences to ensure effective communication. Additionally, the Office of Deaf Hard of Hearing Services is working with its contractors to promote video remote interpreting, so VRI services as an option during COVID-19. And while the Office of Deaf Hard of Hearing Services is aware that VRI service is not effective in some situations, such as those that who are deaf-blind, and for areas that don't have great internet access, it still is a communication medium that still allows the social distancing option.
Okay, next question. My concern is for individuals who are receiving HCBS at this time who have lost those services. Now they are either hanging in the balance at home or have no choice but to be institutionalized. What are the options when a support professional is not allowed to continue providing services due to COVID-19 restrictions other than institutionalization? I fear that this is going to do great harm to independent living.
So this is Dana Williamson with Medicaid Chip Policy. Individuals with Medicaid financial eligibility ending on March 18th through April are automatically being extended so that there should not be a loss of Medicaid financial eligibility. In addition to that, HHSC has also extended level of care and service plan authorizations for individuals receiving HCBS waiver services to ensure that there is no break in waiver eligibility for waiver programs or personal assistance programs. So, we have provided guidance to our contracted providers, managed care organizations doing the same, that they are required to continue to deliver essential services. Obviously, essential services can vary by the individual. HHSC has directed providers to work with the individual's physician to determine what is essential.
Okay, next question, and I think we're getting to the home stretch here. We may hit all of them. Are in-home therapies like OT, PT, and massage for pain management still taking place? If not, are there plans to create an infrastructure for therapists to guide individuals via video chat?
This is Dana again. HHSC sent out information to Medicaid managed care organizations, reminding them that they have to allow for remote delivery of medically necessary and appropriately covered services, which includes allowing occupational therapy, physical therapy, and speech therapy to be delivered as a telehealth service following current licensure requirements. HHSC is also allowing authorized occupational therapy, physical therapy, and speech therapy for individuals of all ages to be delivered as a telehealth service in the fee-for-service Medicaid delivery option through the end of April 2020. In addition to that, we have recently released guidance for the Community Living Assistance and Support Waiver, our class waiver, that includes the ability to deliver physical therapy, occupational therapy, speech therapy, recreational therapy, music therapy, behavior support, dietary services, and cognitive rehabilitation therapy via the telehealth delivery model. Our home and community-based services waiver and our Texas Home Living waiver already provide the flexibility to deliver all professional therapies using telehealth.
Okay, next question. I think we have answered this question. It's about hospital visitation and ADLs and support. We've answered this twice. So I think I'm going to go to the last question. Yes. Some families and consumers use the Consumer-Directed Services, or CDS model, meaning they're technically the employer and hire, fire, and train their attendants. HHSC policy states you cannot hire your spouse or parents to be attendants. Given the pandemic, many parents are forced to be attendants for their children 100% of the time, since they're uncomfortable letting outsiders into the home. Some of these same parents are now working from home and providing 24-hour care for their child. Will HHSC consider allowing parents to be paid as the attendant in the class waiver, even if they are the employer of record? Funding is already approved and in the person's budget.
This is Dana Williamson. HHSC is considering a number of different options to support providers and CDS employers to address workforce shortages and limit the exposure from individuals coming into an individual's home. In our programs, there is the allowance for family members living in the home or other individuals living in the home who can meet the provider qualifications for delivering a particular service, that those individuals are able to deliver the service. There was one program, or actually two programs, the Home and Community-Based Services Waiver and the Texas Home Living Services Waiver, that did prohibit individuals living in the home being allowed to provide Medicaid services and be reimbursed. And so we have lifted that prohibition for the HCS and Texas Home Living programs in the hopes that this will assist with the attendant workforce shortages that families are experiencing and allow individuals that are currently living in the home, family members and others that may be living in the home that can meet the qualifications to deliver the services to be paid to do so. At this time, we have not removed the prohibition against parents of minors and spouses. That would require not only some waiving of local state regulations, but would also be something that would have to be waived at the federal level, because there are federal regulations that prohibit this as well.
Okay, so it looks like we're actually managing to wrap up early, and I forgot to do this at the beginning. So if Justin, if TEA has any closing remarks, you're more than welcome to do so, and then the same for HHSC. I know I'm putting you on your toes. I'm sorry.
That's okay.
I didn't think we'd finish early.
That's okay. The only thing I would, so TEA is, we're working hard to communicate with all stakeholders. We hold weekly webinars with LEAs. We hold webinars twice a week with all ESC special education directors. Next week, I'm participating in a webinar with, Partners Resource Network, to specifically for parents, trying to provide as much information as we can. But just know that in addition to that, there's a plethora of information available on the TEA website, and we are continuing to develop and put out that guidance as it becomes available. There is a significant amount of guidance being created for LEAs right now that should be posted in the next week. I've been saying that for a couple of days now, so hopefully we get it posted. But we know this is unprecedented situation. We know this is really hard on everyone involved, and but we're 100% sure that Texans are going to get through it, and we're going to be better on the other side of it. So everybody hang in there and let us know what more TEA can do to support.
And then Dana, I think you mentioned a weekly Medicaid webinar or something like that. Is that something that members of the public can sit in on? And I may have made that up as I'm reading these questions.
No, you are correct. I did mention that we're having weekly webinars, and sorry, I also have a dog.
He doesn't want you to share the information. Is it on HHSC's website? Is that something, and maybe one of Dana's coworkers can back her up on this?
This is Michelle Dionvaholic. Yes, those webinars and the links and the days, times are on the HHSC COVID-19 page. Again, you could go under providers. The provider box sits to the right as soon as you get to the main COVID page, and find those notices there. In addition to the weekly Medicaid calls that are extremely beneficial, long-term care regulatory is having weekly calls for providers. That includes HCS, Texas Home Living providers, ICF IDD providers, as well as nursing facility providers. If someone feels they would like to hear that information, they certainly are able to join that meeting. You can also look online and you'll find the previous webinars because they've been recorded and the archive links are there.
Wonderful. And
hopefully I didn't miss anything for you, Dana.
No, I think you got it all.
You did great, Michelle. Thank you.
Most welcome.
Okay, if that's it, I'll just reiterate that the questions that we didn't get to, I know we have extra time, but these questions were very kind of labor intensive and dense. So we will be following up with written responses to those questions as quickly as we can. And our office will send that out. And I want to thank everybody again for agreeing to participate and, you know, spending your time answering these really important questions. I know that everybody really deeply appreciates it.
I want to thank everyone as well for attending the Accessibility and Disability Policy webinar this month. In addition, the recording will be posted to our YouTube channel. It takes a day or so before it's up there. And we will send that link to all participants with the training materials and the captioning transcript. HHSC has also provided additional resources, and I will go through the chat feature where some other information was shared, some links to special websites, and pull those and put those in a follow-up email as well. In closing, I would like to thank Michelle, who is with Texas Closed Captioning, for providing the captioning services. And I thank you all for being here. Have a great afternoon. Bye-bye.